Welcome everybody to the 6th in the series of webinars that the European Pulmonary Fibrosis Federation is putting on between a few months ago and the upcoming summit, the second European Pulmonary Fibrosis Patient Summit, which is to be run from the 3rd to the 5th of November. My name is Steve Jones. I'm the president of the European Pulmonary Fibrosis Federation for the current 2-year term. And I'm really pleased to have with us tonight 3 excellent, well-known, renowned researchers from Europe to talk to us with their recollections, their thoughts, their key takeaways from patients from the ERS, European Respiratory Society Congress that was held in September. We have Dr. Elizabeth Renzoni from the Royal Brompton Hospital in London. We've got Dr. Muhunthan Thillai from the Royal Papworth Hospital in Cambridge in England. And we've got Dr. Karen Moor from the Erasmus Medical Centre in Rotterdam. So we're really looking forward very much to what they have to tell us, and they're going to go in the order that they appear on the screen there when we come to it. And the summit itself, for those of you who aren't registered already, we invite you to register. We've got a really exciting summit this time. The second time we've had the summit. Unfortunately, we're still having to do this virtually, but we're hoping in 2024 that we'll do a face-to-face summit for many hundreds of people coming together as one venue in Europe. But the summit this time, 3rd to the 5th, we'll cover a range of topics that you can see on the screen here. Topics related to research, topics related to advocacy, topics related to patient and patient concerns. So I think you'll find it a really exciting program, and there will be live translation into French, Spanish, Italian, Greek, Bulgarian, Dutch, Polish, Portuguese, German, and Romanian. We're getting better at this every year. I look forward to the day when we can have every European language with translation to reach out to all patients. Next, please. And just to say that, final point, that we are recording the session tonight, and a full recording of it will be available on the EU-IPFF website in due course. And we're also going to produce a 10-minute summary of what is the key points from tonight, which will be translated with subtitles into 8 different European languages. And that will be available also on our website quite soon. So without further ado, it gives me great pleasure to invite Elizabeth Renzoni to talk to us from coming out of the ERS Congress, updates on non-IPF interstitial lung diseases. What do you think was good for patients, interesting for patients, Elizabeth?
It's a real pleasure to be here. Thank you, Steve, and to share with you what I thought were interesting studies presented at the ERS. These are my disclosures, and I'll be focusing on connective tissue disease associated ILD. So just briefly, connective tissue diseases are characterized by an overactive immune system, which can attack a range of internal organs, including often the lungs, causing a mixture of inflammation and fibrosis in different proportions. Interstitial lung disease is most commonly seen in certain connective tissue diseases, including systemic sclerosis or scleroderma, rheumatoid arthritis, and inflammatory myositis. And across CTDs, interstitial lung disease is one of the key causes of reduced survival and reduced quality of life. Just briefly, the most common morphological patterns, and this is a CT slice, in the context of connective tissue diseases are non-specific interstitial pneumonia, or NSIP, and usual interstitial pneumonia, or UIP. And I mentioned this because the first study looks at rheumatoid arthritis, and in rheumatoid arthritis, differently from the other connective tissue diseases, UIP is the most common pattern. In the others, NSIP, which tends to be more of a mixture of inflammation and fibrosis rather than predominantly fibrosis as UIP occurs. And I'll be speaking about 2 key clinical trials in CTD-ILD, which were presented. And the reason why this is important and a breakthrough for patients is that up to now, we had only had randomized clinical trials published in Scleroderma ILD and nothing on the other CTD-ILD. So the first one is TRAIL-1, which looks at antifibrotic agent pirfenidone, which is used in IPF but is not licensed for use outside of IPF. Pirfenidone in patients with rheumatoid arthritis associated ILD. This was a 52-week trial of pirfenidone versus placebo. The target for recruitment was 270 patients, but unfortunately, the trial was interrupted because of the COVID pandemic. And therefore, less than half of what were planned to be recruited actually were randomized to the trial, 63 on pirfenidone, 60 on placebo. To be included, patients had to have rheumatoid arthritis and ILD, background stable treatment for the joint disease, at least 10% extent of fibrosis on CT, and patients with extremely severe ILD were excluded. And here are the baseline characteristics, and you can see, for example, that fibrosis extent was considerable, on average more than 20% in both the pirfenidone and placebo arm. And you can also see that UIP was the predominant pattern, with a slightly uneven distribution between the two treatment arms. The primary outcome was decline in FVC by at least 10% or death within the 52 weeks of the trial, and this was not met. So there wasn't a significant difference between the two arms, but two key secondary outcomes, so the change in FVC in milliliters and in percent predicted, were met, i.e. there was a significant difference between the placebo-treated patients here in pink, who on average lost 146 milliliters, compared to those treated with pirfenidone, who on average lost 66 milliliters, with an estimated difference between the two arms of 80 mils per year. And you can see here that the effects of the separation between the two arms in red placebo, in blue pirfenidone, starts happening early on and then increases as the weeks go by. Similar results when FVC, so forced vital capacity, is expressed as percent predicted. No differences between the two arms in serious adverse events or in treatment-related, and there were no treatment-related deaths. And then interestingly, and this is a sub-analysis, when the authors looked at UIP pattern versus non-UIP pattern, the difference between pirfenidone and placebo was even stronger in the UIP, so a difference of 126 milliliters, highly significant. And interestingly, no difference was observed in the non-UIP pattern between the two arms, no significant difference. So in conclusion, from this study, we saw the primary outcome was not met, but almost certainly this was because of insufficient numbers and perhaps the choice of the primary outcome. However, the key secondary outcome of reduced forced vital capacity decline was met with a key difference, a significant difference between pirfenidone and placebo, suggesting that pirfenidone is indeed effective in reducing the rate of decline in ILD patients with rheumatoid. The effect in this study appeared to be limited to patients with a UIP pattern, although the numbers of non-UIP pattern patients were so small that we can't make any firm conclusion on this finding. And then I'll move to the next trial that I wanted to speak about, and that's the RECITAL trial. So just as background, RECITAL focused on rituximab, and rituximab is a monoclonal antibody that eliminates B cells from 6 to 12 months. And B cells are one of the key immune cells. It's used already in a number of autoimmune conditions. And there had been a number of studies, retrospective or proof of principle, including our own, that had suggested that rituximab could be effective in CTD-ILD. In the RECITAL trial, rituximab, 1 gram repeated after 2 weeks, was compared to IV cyclophosphamide, which is one of the immunosuppressant drugs, intensive immunosuppressive regimens that are used in the context of CTD-ILD. in patients with scleroderma, mixed connective tissue disease, and idiopathic inflammatory myositis. The primary outcome was the FVC, so the change in forced vital capacity at 24 weeks, but follow-up was also instigated at 48 weeks. So here we have the design of the trial. Patients to be eligible had to have severe or progressive ILD requiring intensive immunosuppression. Background corticosteroids were allowed at a dose at the discretion of the treating physician. There were 51 patients randomized to rituximab, 50 to cyclo, and this is the division across the three different connective tissue diseases. In terms of the primary outcome, so the change in forced vital capacity over 24 weeks, at 24 weeks, there was a significant improvement in FVC by about 100 milliliters in both the rituximab and the cyclophosphamide arm, with no significant difference between them. That improvement was maintained at 48 weeks. So both drugs improved forced vital capacity at 24 and 48 weeks. There were no significant differences between rituximab and cyclophosphamide. Quality of life measured by questionnaires, including K-BILD, was also improved by both drugs. Numerically fewer adverse events and a lower corticosteroid dose was reached with rituximab, and the authors conclude that rituximab should be considered as an alternative to cyclophosphamide in individuals with connective tissue disease associated ILD. And with this, I look forward to the discussion at the end of the speakers. Thank you.
Great. Thank you very much, Elizabeth. That's really good news. 2 trials, quite positive, bringing new hope for people living with connective tissue disease, ILD. Really, really, really good. Great. So Muhunthan, over to you. And
thank you very much.
Great pleasure, Muhunthan Thillai from Papworth Hospital and the University of Cambridge.
Thank you very much, Steve. I am hopefully moving forward a slide. Yes, these are my relevant disclosures. So I'm going to present 4 brief studies from the ERS that I found quite interesting. It's important to say that there were a number of new drug trials at the ERS, and I'm not going to touch on them, but I do have a couple of slides at the end about all the excitement and the new drugs that we might have for IPF. But here are 4 studies that I think are particularly interesting, especially to patients and carers. And I'm going to briefly explain why I think they're important, a summary of the work, and then the key take-home messages from each of these 4 studies. So this is the first study by Hoyer and colleagues from Denmark, and this is about the delay in diagnosis for IPF. So we know that a number of patients with IPF take a very long time to get an accurate diagnosis. And even in specialist hospitals such as mine or Elizabeth's or Karen's in Europe, diagnosis can be very complicated. We have lots of MDTs and we come to a decision, and it can take some time. And one of the key questions for us as doctors treating IPF patients is, does this delay affect survival? We think it does, but there's limited data showing this. So this is quite a nice study that came out of Denmark. So in this study, they looked at 264 patients in one big, large Danish hospital, and they followed patients up for quite a long time, 5 years in total, and they collected multiple data points for each patient. So questionnaires, rates of hospitalization, and of course, death rates in these patients. And what they found quite strongly, with quite a good level of significance, was that if your diagnostic delay was more than 1 year, so more than 12 months to get an actual diagnosis from time of symptoms, then your survival was significantly worse. And really importantly, this was particularly so in the patients who we would think of as having mild disease, so a forced vital capacity of over 80%. And in the UK and other countries, we call that mild IPF. They also showed that with the use of St. George's respiratory questionnaires, that patients who had a long delay actually had worse symptoms. So in summary, this study clearly shows that if you leave it longer, especially over a year, then patients with IPF are more likely to have lower survival. And importantly, even in the time that they have a worse quality of life. The study also showed that hospitalization rates were higher in those with a delayed diagnosis. And so the key summary for me, and I think the key summary for everybody here, is that data like this shows that it's really important to get an early, prompt diagnosis of IPF, that your survival is significantly longer if you diagnose the disease earlier. So this was a nice study from Denmark. The second study I want to present is a study from Plattenberg and colleagues from the Netherlands. And this looked at the drugs pirfenidone and nintedanib in a little bit more detail. Now, we know from the studies, and the main studies in the New England Journal of Medicine on both these drugs are now 7 or 8 years old, but we know from those studies very robustly that the antifibrotic drugs that we have today around the world can slow your rate of lung function decline, your FVC decline. But those studies didn't look in great depth at survival. They said we slowed the level of lung capacity drop, but they didn't really investigate whether these drugs actually make people live longer. There is increasing real-world evidence about this, and studies such as this from the Netherlands are really important because they add weight to the evidence that, as well as improving the drop in lung capacity, the antifibrotics that we have, pirfenidone and nintedanib, are actually able to improve survival. So in this study, they looked at quite a lot of patients, 457 patients from a big centre in the Netherlands, and they looked at what we call transplant-free survival. So the idea that patients with these drugs lived to either a transplant or lived on to whether they died or not. And this showed clearly that when you divided up the patients into 2 groups, those who had antifibrotics lived significantly longer, 3.5 years, versus the non-treated group of just over 2 years. And importantly, when they adjusted patients for what we call a GAP score, and the GAP score is a way of looking at severity of IPF. So when they adjusted patients to that baseline of GAP, i.e. took patients with the same level of IPF, those on drugs lived longer. And again, this underscores the importance of treating our patients with IPF with antifibrotics. So the third study was a slightly more scientific study, but was quite interesting in looking at the lung itself. So this study comes from Scotland, from Edinburgh, from Lee and colleagues, and this looked at lung washings in patients' lungs with IPF. Now, the background to this, and there are other studies like this, are that patients with IPF behave differently in terms of their lung physiology and anatomy than patients with no IPF. Those with IPF get lung scarring, we see changes in the blood vessels and the fibrotic tissue. And there are lots of ways of looking at these patients over time. We obviously do CT scans. Sometimes we do CT scans over a period of time, and there are lots of new algorithms coming out looking at changes on the CT scan. We do breathing tests in the hospital, spirometry or full lung function tests to see whether patients get better or not. But we also sometimes do bronchoscopies, lung washings. Often this is done at the time of diagnosis, and in the clinical world, we do lung washings really to look for IPF or other forms of diseases. But we do know that when you look at the actual molecular structure of the lung, you find some very interesting things. So this study looked at just a very small number of patients, 6 patients with IPF and 6 healthy volunteers. And in their unit in Edinburgh, they carried out bronchoscopies and washings, and they used a type of multiplex analysis. So they took the little washings from the lungs and they carried out a series of effectively protein markers to see what sorts of markers, what sort of biological molecules were going up or down in the lungs of IPF versus those without. And they found a number of markers, 6 in particular, that seemed to be very different in IPF. And one of these they found was a protein we called amyloid precursor protein. And now that's important because lots of studies in the past have looked at blood levels of this and found that in IPF, patients have a higher blood level of this particular protein. So this is quite a small study, but it does add evidence to the fact that the biological markers within the lung are definitely different in IPF. And the reason this is important is that when we develop new drugs for IPF, it's really important to understand what we're targeting. And by measuring these biological markers in the lung, they may actually help us look at new drug trials for new drugs for IPF. And so the fourth and final study I want to talk about was about COVID, because we can't get away from this webinar without talking about COVID. Now, we know that patients with IPF and other forms of ILD are potentially at higher risk of COVID, and there have been some nice studies. There was quite a large one from centres across the UK in the American Journal of Respiratory and Critical Care Medicine last year, looking at the fact that patients with ILD and IPF, particularly in COVID, are at high risk of having serious consequences. But this study from Hungary, from Toth and colleagues, looked particularly at COVID vaccination. So we know that COVID infection is a concern, not just for IPF, but anybody with a structural lung disease. And as healthcare professionals, we routinely encourage all of our patients, at least we hope we do, to have COVID vaccines. But we do know that some patients, even those with IPF, are reluctant to have the vaccine because of concerns about vaccine safety with underlying lung disease. So studies such as this are really important to look at COVID vaccine safety in a bit more detail. So this again was a small study, but it was a study from Hungary, and they looked at 70 patients with IPF. And of those 70 patients that were recruited to their clinic, 68 patients had at least 2 doses of COVID vaccine, the majority of the Pfizer-BioNTech vaccine. And importantly, none of those 68 patients who were vaccinated and who had IPF were admitted to hospital with COVID pneumonia. The study did not give us information on infection rates, but it was important to know that none of them got very sick with COVID. However, in the group of 2 patients who didn't have vaccines, unfortunately, one of them died having had COVID and COVID pneumonia. So this is a really small study, but I think it's really important that studies like this are talked about to encourage our IPF patients to say that the COVID vaccine is safe, and all our patients should be encouraged to have it. So I've talked about 4 studies. I haven't talked about drugs, and I have 2 slides to talk about this. At the conference, I went and listened to a lot of companies, big companies and very small companies, announcing interim or early results from early phase or phase 2 studies. So these are studies that look at new IPF drugs before they're carried out in what are called large phase 3 studies. Some of these studies only had 10 or 12 patients, some of them had 70 or 100 patients. But there are a few interesting themes that I wanted to talk about without going into specific drugs in detail. A number of these studies had shorter time. So with the pirfenidone and nintedanib studies from 8 years ago, those were 1-year studies, 52-week studies. Some of these were shorter, and some of these companies are planning on doing shorter studies, maybe 6-month studies rather than 12-month studies. The other important thing to know that when we had the pirfenidone and nintedanib studies, they were against placebo. There were no other drugs. A number of these newer studies are looking at multiple arms. So sometimes the new drug, sometimes the standard of care, so pirfenidone or nintedanib, sometimes the placebo, and sometimes the new drug plus pirfenidone or nintedanib. So this starts to make trial design very complicated as we go forward. A number are also employing novel endpoints, imaging endpoints, and different sorts of biological markers, rather than the simple breathing tests that we had for the pirfenidone and nintedanib studies. So my take home from this is that, first of all, we have a number of drugs coming on the horizon. There are a number of large phase 3 studies next year. So as an IPF community, we're quite excited about the potential new drugs. However, the trials are very complicated. They have multiple arms and multiple endpoints. And this means that we're now moving towards an era where IPF will be treated a lot more like cancer. We've talked about this for many years, but as IPF physicians, we can now see multiple drugs coming, and these drugs will be needed to be targeted towards specific patient groups. And I can clearly see a point in the next 2 or 3 years where patients will be on multiple drugs. And as physicians, we'll have to decide which of those drugs or which combinations of those drugs are best for patients. So that's actually quite exciting and should open up a whole new avenue of drug treatment for IPF. So thank you very much. I hope that at least one of you is awake, and the rest, and at least one of you is awake, and not everyone's asleep. And I'll hand back to Steve.
This was a photo from the ERS, was it?
Yeah, I'm somewhere in the back. I was definitely paying attention.
You're definitely there. You had too much champagne the night before, too. Okay, no, that's very great. Thanks, Muhunthan. That was really interesting. And really, I mean, both of these talks so far, really new and challenging thoughts for people living with pulmonary fibrosis. Just to remind you, all of you listening, that if you'd like to put some questions into the Q&A, we'd very much like that. So start putting your questions in, and we'll be turning to them after we've heard from Karen Moor from Erasmus Medical Center in Rotterdam. Over to you, Karen.
Yes, Steve, thanks a lot for the kind introduction. And tonight I want to talk to you about symptom management and some new technologies we saw at this year's conference. Yeah, slides are moving. And I want to use this figure, this ABCD of ILD care, to get you through the discussion. This goes from diagnosis up until the end of life. And then we start at the best place of care for patients. And one study in the ERS looked at outcomes of patients in specialized ILD centers versus non-specialized centers. And it was a German studies, and they looked at health insurance data. And they looked at patients being treated in ILD expert centers, around 2,000 patients, compared to other patients, which were around 29,000 patients treated in other centers. And here are some of the results. What we saw is that the mortality was lower in patients being treated in specialized ILD centers. That are the blue dots, and the red line is the non-specialized centers. And also the 1 year hospitalization was lower in patients being treated in specialized ILD centers. So I think the study highlights that it's important that there's a good cooperation between ILD centers and non-specialized centers. It doesn't necessarily say that everybody has to be referred, because there may also be differences in patients being treated in ILD centers and non-specialized centers. Then we go over to symptom relief and treatment of dyspnea, cough, fatigue, and depression and anxiety, which I think is very important. There's one study presented some advances in treatment of cough. There was a phase 2 trial, which means that they looked at effectiveness of nalbuphine, and that's a sort of opioid. So it resembles morphine, but it has a lower risk of dependence. And it was a crossover trial, so it means that patients, some of the patients were first treated with a placebo, and other patients were first treated with the nalbuphine, and then they switched. And they did an interim analysis, so an early analysis after 26 patients. You can see that the baseline cough count was 31 coughs per hour, so that's quite a lot. And what we saw is that there was 50% differences in cough in patients treated with the drug and with placebo. So I think these are very promising results, but we should wait the final results when the study is completely finished. Then there was also a study looking to breathlessness, and they used handheld fans. So something like you see below, it can also be even smaller. And 38 patients were recommended to use a handheld fan. What the researchers saw is that 63% of patients considered the fan effective for dyspnea, 3% said it didn't work, 3% thought it was too cold, 21% didn't fill in the questionnaire, so we don't have any data, and 10% already died before the follow-up. But overall, it seems quite effective, and it's very easy to use, obviously, and the handheld fans are very cheap, so it could easily be implemented. Then a study in sarcoidosis, so that's a disease that can cause pulmonary fibrosis. Not all patients in the trial had pulmonary fibrosis, but they looked at an online mindfulness therapy, and they randomized patients to either the mindfulness therapy or to just standard care. And it was an online mindfulness therapy, so it was patients did different exercises during 12 weeks and were helped by a psychologist. And 99 patients with severe fatigue were included, and 50% of them also suffered from anxiety and depressive symptoms. And what we saw here, lower scores, well, it's better, and that the fatigue in a questionnaire was getting way better in the group with the online mindfulness and was stable in the control group. The same was found for anxiety and for depression. So it really helped most of the people, and I think it can also be used for other chronic diseases. There was one study in IPF looking at anxiety and depression, and there was a study that did pulmonary rehabilitation in a group of 240 patients with IPF. And then around 1/3 of those patients either had anxiety or depression at baseline. What they showed is that pulmonary rehabilitation also worked for anxiety and depression. So the scores were lower after the rehabilitation program. So I think these two studies are very promising and offer different treatment options for these symptoms. Then I also want to talk quickly about some new technologies. And there are some technologies for education and self-management, and that's mainly the home monitoring. During the COVID-19 pandemic, many centers started with doing some home monitoring with a pulse oximeter or with a home spirometer. You can see that here at the right. And this was an observational study in 60 patients to assess whether it was feasible during the pandemic. And that study had a duration of 90 days. And what we see here are some of the results of the adherence. So did patients actually measure their lung function at home, and did they measure their oxygen saturation at home? And you can see that more than 1/3 of patients did record it on more than 70% of the days. And it was a little bit more for the pulse oximetry, but that's obviously it's a little bit easier than doing the home spirometry. So 82% of the patients even continued after the study ended. So they wanted to continue doing the home spirometry and the pulse oximetry. And patients measured on average on 91% of the study days. But then the question is, do they actually like it? And that's where a survey in the Netherlands looked at. It was a survey among 116 patients with pulmonary fibrosis, which used this home monitoring program during the COVID-19 pandemic. So they did questionnaires, home spirometry and pulse oximetry, and could see their results, and the doctor could also see it. And what we saw is that patients actually considered it very easy to use. The overall satisfaction was high, with a score of 8.1 on a scale from 0 to 10. And the home spirometry was considered not burdensome. Patients considered it easy to use, and they especially considered it pleasant to see their own results over time. So I think it can be used to replace part of the care. So not all care should be at home, but we maybe can go to some more hybrid care models where patients only need to go to the hospital when it's really needed. In this study, we replaced 50% of outpatient clinic visits by the video consultations, and 89% of patients want to continue the home monitoring after, even after the COVID-19 pandemic. And then two last new technologies for correct diagnosis and also for assessing response to treatment and prognosis. This one I'm gonna explain very briefly. It's an electronic nose. What is it? You can see it below here. It's a sort of, it doesn't really resemble a nose, but it has 7 sensors, and the sensors really capture your breath. And in exhaled breath, there are different compounds. And we think that every disease patient have other compounds in their breath. And with this electronic nose, you can really make sort of a breath print and to see what diagnosis the patient has. And it already had some promising results to distinguish different forms of pulmonary fibrosis. And here we looked whether it also can predict response to treatments. So there were 24 patients on antifibrotic treatment, either nintedanib or pirfenidone. And patients measured the eNOS before the start of medication. And we looked whether we could predict the response to treatment, measured as a change in lung function. So we compared patients who were stable, who had a lung function decline. And you can see all the dots, the blue dots and the red dots are different patients. And you can see that there's sort of a difference in breath prints in the patients who were stable and the patients who had decline in lung function. So this obviously has to be validated in much larger studies, but I think it can be very promising to have such an easy tool. And then the final study, Steve, a little bit over 10 minutes, but it's the last one. It's an artificial intelligence CT algorithm to predict outcomes. What did the study do? It used large databases with CT scans of patients with pulmonary fibrosis, but also with lung function and survival data in 280 patients. And there was sort of, the computer made an algorithm which made a sort of score of the CT without radiologists having to do that. And they saw if this score, the EILD score, could predict disease progression. And what they saw is that it actually did better than lung function. And it really was possible to predict lung function decline in the future. So also this, I think it's very promising. And these were just a few of the new studies I wanted to share with you.
Great, thank you very much indeed, Karen. That was great. I've got some coming in on the Q&A here. I've got some other ones coming in to me on WhatsApp next to me here. Let's start off with a couple for you, Karen, if that's all right. On the cough study, have you, well, two things, one on the fan study and one on the cough study. On the cough fan study, have you considered the psychological effect, the placebo effect, in using handheld fans for breathlessness? Is that part of it? I mean, not you personally, but did the researchers, sorry. Yeah.
I think it can be part of it. The idea is that it's sort of stimulated because of the cold air, that it's that helps, and also maybe stimulate the nerves associated with breathlessness. But I think it can have some psychological effect. But if it does, I don't think it's a problem, because if it helps and if you feel, or if the breathlessness is getting reduced, then it's a good thing. And I actually don't know, because if you want to study that, you should really do a randomized trial. But it's so easily available and cheap that I don't think people will ever do a randomized study. And that's why they just did this study, I think, with questionnaires to assess.
That's great. Yeah. There's a question on cough as well, one that I can, from my own experience as an IPF patient, understand, is you can measure the number of times you cough in a day. But there's a much, cough is a much broader experience for the patient. It's both the strength of the coughing, the effect it has on you, and for many patients, it's a different type of cough. I mean, I know my cough changed over my 8 years with IPF. Started as a tickly cough, which is probably, felt like a sort of, I don't know, neurological cough, if you like. But later on, I was producing huge quantities of sputum, and it was very much a wet cough. So how do you, in these cough studies, and there are a number of them going on now, how do you get around that? How can we get some qualitative measure of what cough means?
Yeah, well, in these studies, the objective cough count, so with the cough monitor you saw on the picture, is the primary endpoints. But there are always also questionnaires included. So there's a few questionnaires that really analyze the impact that cough has, and then sort of the cough-related quality of life. Yeah. But also maybe show an easy visual analog skills. So how much do you cough, and what kind of cough? Do you have an urge to cough? And also how much does the cough affect you? So I think these are really important patient-related outcome measures, because it's not only the cough itself, but also the impacts. And studies show that it's related with the objective cough count too. But I think the whole study will reveal whether it also impacts quality of life, and I hope so.
Yeah, thank you very much indeed, Karen. Muhunthan, you got everybody very excited at the end there with all of the IPF drugs that are coming, hopefully coming along in the pipeline with I think we've got three phase 3s going on at the moment, but this is going to be another 3 or 4 coming too. We know they don't all succeed, sadly, but it's a very encouraging thing. So how are we going to get the patients to take part in these trials? I mean, at the moment, we're not really very good at that, are we? We find it difficult to recruit, and some places find it difficult to retain patients. What are we doing wrong?
Yeah, and actually COVID has made this significantly harder in terms of bringing patients in. So you may have seen there are a number of other types of fibrotic trials going on using remote monitoring, some of the stuff that Karen mentioned. So this idea that actually if you could remotely monitor somebody's lung capacity through a handheld spirometer, if you could Bluetooth that data into your computer and then to a central database, if you could reduce the number of patient visits into hospital, I think we need to think about much smarter ways of enrolling patients into studies. And as I said, it's hard enough with COVID, but the other challenge is that we now have drugs for IPF. In the past, when we had no drugs, patients would be very keen. But now that we have drugs for IPF, we need to be able to persuade patients to take additional drugs or find patients who, for some reason, are not eligible for standard of care. So that is a really big challenge.
I mean, I know in the UK, if you look at where the pharma companies go to, they go to the same 12 centers, basically, roughly. I mean, 70% of all the trials take place in those same centers. What about all the other specialist ILD centers? What about all of the district general hospitals? I mean, what's the problem in getting those patients from those places more involved in trials?
I think that comes back to the MDT process. So, I mean, as you said, most of the trials go through large centres. I think Elizabeth probably gets most of them at the Brompton, but some of the rest of us are trying to get patients. But it's really important to get the peripheral hospitals involved. So in Cambridge, we have a virtual MDT where we bring patients from the smaller hospitals in virtually. And we use that for starting antifibrotics and monitoring patients. We haven't used that for trial recruitment, but that might be a novel way of using that and sort of piggybacking onto the virtual MDT system to recruit patients. But you're right, if we don't recruit patients better, we won't get patients into these studies, unfortunately.
Yeah, and there's a couple of questions, a lot of interest around diagnosis, as we know, late diagnosis. I mean, two questions really. One, it's difficult for you guys when they reach you. How can we get them to you quicker? You know, so in other words, then that's a problem both, I guess, before the GP, in raising people's awareness and with the GP. You know, what can we do about that?
I think it's about education, and we've said this for years. It's really about educating our healthcare professional colleagues in the non sort of IPF specialties to think about IPF. You think about a cough in primary care, and it's how do you get that first chest X-ray? How do you get somebody to get a CT scan? In secondary care, you have a CT, and how do you get them to tertiary care? It's about pathways and moving people along those pathways as quickly as you can, I think, more than anything else. So
we need a pathway similar to the cancer pathway for patients where
I mean, if you had a sort of 2-week IPF pathway, we definitely move patients through that very quickly.
And then a 62-week treatment. That might put pressure on you guys too.
That would definitely would.
I mean, because that was a really interesting study you talked about. I mean, so patients who come late do less well, basically. What's the reason for that? Is it that they are a shorter period of time on antifibrotics, or is there some other reason?
I think it's a combination of things. It's not rocket science to think that the later you diagnose a disease, that the worse they'll be. But it's less time on antifibrotics. It's less time in the system because it's not just drugs. When they come to specialist centres, I guess anywhere across Europe, you have access to a multitude of things in addition to antifibrotics. So specialist nurses, good oxygen support, links to pulmonary hypertension teams, links to transplant, and links to palliative care. So I think it's everything, not just the drugs they're missing out on.
Okay, that's great. Thanks very much. Elizabeth, hi. The really interesting presentation, I think, for patients living with non-IPF pulmonary fibrosis have had a hard time, basically. I mean, fortunately, nintedanib and maybe in the future pirfenidone have been made available to patients in the last year, or year and a bit, which is absolutely great. And now the IPF patients are looking in the UK are looking enviously at their colleagues with other forms of pulmonary fibrosis, because they do get access. But what is for you as a clinician when you're faced with a patient? If I'm a patient, I think a no-brainer, antifibrotic, I want it. Is that automatically the choice, or is it a question of going through the immunosuppression route first? And how do you make those decisions? I know there's a number of patients on the call today who have those conditions.
No, absolutely. I mean, that is one of the key questions that we have as ILD physicians, is to make the correct diagnosis, because I was speaking of connective tissue diseases, and if you catch a connective tissue disease early on, and especially certain types and certain patterns on CT, the treatment will be anti-inflammatory and immunosuppression, and antifibrotics would have very little effect on those patients. And so, as Muhunthan was saying, for IPF, I think we also need to catch not only patients who have fibrosis early, but also patients who have significant inflammation early. Because if you lose that window of time when they can respond to anti-inflammatories and do quite well, and they have then developed instead extensive fibrosis, it's too late for immunosuppression to have a major impact. And so I guess that's why it was so good to see the RECITAL trial. Up to now, because scleroderma is the one that most commonly has, or the patients with scleroderma most commonly suffer from ILD, all the randomized clinical trials that have been done so far have been done in scleroderma ILD. And RECITAL is the first one that looks at a broader range of connective tissue diseases. And both with rituximab and cyclo, you actually get an improvement in lung function, something that we never see with antifibrotics, because the disease is different, and it's later on in the disease course. So antifibrotics aren't the answer for everything, and indeed anti-inflammatory and immune modulation can actually have quite a striking benefit if used in the right patient at the right time.
I mean, I know I've quite a few patients in the old days on immunosuppression would find it intolerable and give it up. You know, the side effects could be quite heavy. Would that be correct?
I think right now, I mean, cyclophosphamide can give you lots of side effects in the few days after. And in fact, we don't use cyclophosphamide anymore that commonly. So the routine treatment for a patient with CTD-ILD, which we believe has an inflammatory component, would be mycophenolate, which are tablets. And actually, mycophenolate is reasonably well tolerated by the majority of patients. It's less than 10% of patients that need to stop mycophenolate. Of course, steroids are another drug we use, and we know that if we keep patients on high doses of steroids for long, you can have all sorts of side effects. But I would say that compared to the antifibrotics, mycophenolate, azathioprine, methotrexate, the immunosuppressants that we normally use are better tolerated than antifibrotics.
And do you find in your own experience, either from the nintedanib or this pirfenidone trial, that the intolerance to the drugs, to the antifibrotics, is the same for other forms of pulmonary fibrosis than IPF? I mean, I believe in IPF it's about a 30% dropout rate, although some patients will move from one drug to the other drug. So it's not overall 30, but is it about the same?
I believe it's the same. I believe it is the same. I have not noticed a difference, but I haven't. And in the trials, of course, they are less because they're very well followed. They have access to health professionals, so they tend to be a lot less than 30%. But you're right. In real life, it's quite a proportion. And in certain patients, I don't know, for example, scleroderma patients, you might even get more lack of tolerance because they already have gut problems to begin with. Indeed, and then you're piling on top of that nintedanib, for example. So, but I haven't, aside from that, I haven't noticed differences. I don't know what the others think.
Well, Hunton, do you have any?
No, I haven't noticed any differences other than that they have, as you said, gut problems, or they sometimes have slight issues to mycophenolate and then antifibrotics, but I don't think there's a massive dropout or any bigger than the IPF patients, to be honest.
Great. Good. Okay. So, Karen, a question of whether, do you consider in ILD care, I mean, it's related to your broad area of symptom management, that care should include referral to social workers and psychological support to mental health professionals? And does that happen in Holland?
Yeah, I think that's really crucial. But before being able to do that, we really have to ask patients these questions, because sometimes I think we go onto the real symptoms, the cough, the dyspnea, and forget to ask patients. So I think from both sides, we have to ask it, because once you know it, you can sort of do something about it. And then I think we do refer to psychologists we have in the hospital, but sometimes patients prefer to have it closer to home because they travel a long way to us. But I think also I showed the psychological, the online psychological program, which can also be an outcome for some patients. So I think, yeah, it's crucial, and we do it, but we should do it more, I think.
Yeah, I mean, it's not done, am I fair in saying this is better in Muhunthan? It's not done too well in the UK?
I think that's an understatement, Steve. So we have a very large transplant centre in Cambridge, and they have amazing access to psychologists, and we're really jealous. We have nothing like that, unfortunately, in ILD.
Yeah, I'll talk to you about that one afterwards as well. Okay, I started switching. Okay, so sorry, I'm losing track of my thought now. I shouldn't get involved. There's a question, Karen, are smartwatches reliable for home monitoring of oxygen in the blood for IPF patients?
That depends. There are, I think, smartwatches there are reliable, but there's obviously the problem with all those devices is that they're not all as reliable as the other. So I think that's something that it's difficult to say for all devices, but there are smartwatches that are reliable. But you also do have the normal pulse oximeters and also the Bluetooth pulse oximeters, which do only send, for example, we have one we use and it's incorporated with the spirometer, and then it only sends the results if it's really good measurements, and then you know that you don't get false alarms because it's wasn't measured good.
Great. And Muhunthan, one of the many side effects of nintedanib is listed as being risk of bleeding and stroke. How does this impact on patients with a history of mini strokes or who are on blood thinners? Does that mean they're excluded? Or?
I'll let my colleagues correct me if I'm wrong, but they're not excluded. These are all relative risks. In the very early days, I remember my first nintedanib prescription in Cambridge, and I had someone, and I was very worried. We now take this as a risk, and we obviously do individual risks for individual patients, but being on a blood thinner or having had a mini stroke some time ago is not an absolute contraindication to nintedanib anymore.
That's helpful, thank you. That's good. And Elizabeth, this is a real, I don't even know what the question means, so I'll read it to you. But is there any experience with rituximab in EAA as a replacement for cortisone?
So EAA is what the Americans call hypersensitivity pneumonitis.
Oh,
it's
okay, fine.
Extrinsic allergic alveolitis. That's what it is.
Thank you.
So for hypersensitivity pneumonitis, there have only been small retrospective studies. We had that probably was the first case that was published, a case who did very well for many years, having not responded to cyclophosphamide, having initially subacute, so non-fibrotic HP, and she had been, however, declining on cyclo and then improved and was maintained stable for several years before then progressing on rituximab. Then in our other rituximab retrospective review, there were 6 patients with hypersensitivity pneumonitis. 3 did stabilized, 3 didn't. And then I know the French have also done a study, a retrospective review of around 20 patients with HP, looking at rituximab with an impression that it might stabilize lung function. But these are all retrospective studies. I think when hypersensitivity pneumonitis, when it still has some inflammation, there is a rationale for treating. It's a lymphocytic process, and there is a rationale for treating with rituximab. And so I think if one does a trial, runs a trial in HP and rituximab, it's going to have to be well targeted to the right patient population. But I'm not aware of a study looking at whether rituximab can replace corticosteroids.
And then if you go through that transition from rituximab, say, to antifibrotic, is that a sharp line, or can you overlap them? Yeah.
No, so we're learning increasingly that in some patients, and that has been shown in some of the trials, like in BUILD, there were some patients that were on immunosuppression with connective tissue diseases. In the census trial that looked at nintedanib in patients with scleroderma, half of the patients had mycophenolate and tolerated the two. The 2 were reasonably well tolerated and were safe together. So an immunosuppressant and nintedanib. So we're increasingly learning that at least for mycophenolate, you can use it together with pirfenidone and with nintedanib. I think what we need a bit more data to know about the other immunosuppressants, but in theory, you would not necessarily consider now you stop this and go for that. I think you would continue with both in a, for example, in a CTD-ILD patient, if you think inflammation is still playing a role, but you're also dealing with a progressive fibrotic process.
Great, thank you. Okay, now get your crystal balls out. We're back here in 2030, 8 years' time. Karen, how's the world different for pulmonary fibrosis patients in 8 years' time?
Well,
Don't cover every point, just make one. So
yeah.
give Elizabeth Muhunthan a chance to.
Then I don't go for the medication. No, I'll go for. I think we're going more for hybrid care model. So what I said is that we can treat patients at home when possible and only in the hospital when needed. And we really do have more personalized treatments available, and some new tools like electronic nose technology and everything to diagnose patients earlier and to really say this patient is going to respond to that medication. Well, that's what I hope.
Great, that sounds really promising. Elizabeth, you're on mute. Yep. Sorry.
Continuing on with that, I agree. We would hopefully have more of a subdivision in patients, and drugs that work for certain patients but don't necessarily work for others, for which other types of treatment will be available. I think we might be able to reach stability in fibrosis or prevent progression. I don't know if it's going to be possible by 2030, but I think if one is an optimist, one could think about that. But that there is going to be more and more, as we have more molecular information, differences between different subsets of patients about which drugs to use for which patients.
So more personalized care, possibly the hope of stopping fibrosis in the way that HIV/AIDS can be controlled. Yeah, that would be very encouraging. Yeah, Muhunthan, you had the crescendo. We'll build it up now.
I did. Well, I sort of put them both together in terms of hybrid care and personalized care. And I think, just to give you the example, if we see, or our lung cancer patients see lung cancer patients, they don't just give them chemotherapy. They do molecular testing, they do EGFR mutations, they try and find a personalized drug for that patient. And when that drug fails, they'll add in another drug and another drug. I see IPF now as the sort of pre-personalized lung cancer days. We give people antifibrotics and they slow down progression, which is great. But, 8 or 9 years from now, I really hope we'll be in a position where we look at biopsies, look at blood tests, and as Elizabeth said, find a personalized approach to patients. And that sounds very complicated, but we do this every single day in Europe for lung cancer. People go to lung cancer MDTs, we look at the tissue and we make a decision. And I'm sure that in 10 years, we'll be in that same place with IPF.
That's brilliant. Very encouraging. Really great. Well, thank you, all three of you, very much. We're really grateful for you giving up your time this evening. To Karen, Elizabeth, and Muhunthan, thanks very much. Thank you to everybody for coming and for the questions. We haven't, I didn't manage to put all the questions, but the few that came in late, we'll be directing to the appropriate person to answer them and get back to you. So thanks very much for that. And it remains to remind you that the summit is on the 3rd to the 5th of November. Hope everybody who wants to can come to it, free of charge. It's going to be a great program. And finally, thanks again to our speakers, and thanks to Alba and the team in our secretariat who make these webinars possible. So thank you very much indeed. Have a very nice evening.